And then what evidence supports the use of high-efficacy DMTs as first-line agents in pediatric MS, and how do long-term safety profiles different from adults we already?
We haven't gone into the evidence, but there is a lot of evidence of this. I'm blessed to have mentors who've actually done a lot of research on this. As far as most of the drugs that we have, I guess all of the drugs that we have, the mechanism of action, they work great on inflammation. That is essentially what we're good at. All the modifying disease therapy, that's all they do. We are not good at remyelination. We do not have anything for repair, which is why we cannot cure MS. We do not know how to redo our neurons, for lack of a better word. So why not use it at the time when we know it works best? And it works best at the time when the patients are hyperinflamed. So there's data that has shown this. Not we have more experienced data, like case studies. We have trials that have shown patients how we have switched from the Pediatric MS Network, how we have switched patients, how hard our own practices have changed over the years, and seeing how we have been able to switch patients up from low efficacy therapies to high efficacy, and how we've prevented relapses. So there's real world data out there.
And then with pediatric patients in mind, having the disease for a long time, they're going through different stages of life. And for pediatric patients, that means going through hormonal changes as they get into teenage years and even as they eventually transition into adult care. How do those changes in the body impact
Yeah.
treatment?
Um, Not only treatment, but even diagnosis and presentation. At the time of diagnosis of MS, we know inflammation has started many years ago. By the time you're being diagnosed, you likely have had the disease for a number of years. Um, Most patients are between ages of 18 to 45, and those are ages where they're postpubertal. If they're younger than 18, most patients present after 12. And it tends to happen during after puberty in males and females. We know it affects females more, so there's a hormonal, whether it's contribution or we don't correlation. There's a lot that influences the patient's disease course. We used to think of MS as different types. Now we think of MS as a continuum, or as one. Is it really truly relapsing? Is it progressive? Is it secondary progressive? Don't worry about that. My sense is, as the patient, the disease progresses, our therapies, we don't do this yet because everything we do is evidence-based, but we all know high efficacy drugs, and we talk, and there have been a few talks that have talked about this, to work at not specific, but there are prime ages that this is when we need to use these drugs. What we're not very good at is coming off of them, or at least de-escalating to what we consider lower efficacy. But there is a population of patients we know who are not as inflammatory, so maybe that's the group that they need. Now, is that dependent on hormonal changes? We do not know, but it is a lot to do with aging, which is why we have immunosenescence and MS being less inflammatory as we get older.